Hello, in this video I'm going to talk about elbow injuries, rehab, and considerations. So things we need to know about how the elbow is injured and what we need to consider when we're rehabbing an injured elbow. So a supracondylar fracture, that's a fracture that happens above the epicondyles of the humerus, hence its name, and happens almost exclusively in children and adolescents. So something to remember is that when a force goes through a structure that is great enough to cause injury, it will cause the injury at whatever is the weakest point in that structure. So in children and adolescents, the growth plate is still open. Okay, so the epiphyseal plate is still open if the bone is still growing, and that epiphyseal plate is made of cartilage, which is weaker than the bone. So if a great enough force is put through the humerus, it will cause fracture at the epiphyseal plate made of cartilage as opposed to anywhere else in the bone. That's why it happens almost exclusively in those who still have an epiphyseal plate. May be caused by a fall directly onto a flexed elbow or by hyperextension. So either of those types of forces will cause a fracture at the epiphyseal plate and the distal humerus. Now, the same exact injury mechanisms in an adult who does not have an epiphyseal plate because it is closed would have instead an olecranon fracture. So falling on the flexed elbow or hyperextension on an adult, the weakest point would be the olecranon process, so that bump or that point of your elbow. So could cause acute swelling and or injury to the olecranon bursa. So we have a few we have a few olecranon bursas. One that is immediately underneath the skin. So it's between the skin and the olecranon process. Then we have another that is between the triceps insertion and the olecranon. Not necessarily the insertion, between the triceps tendon and the olecranon right before it reaches its insertion. So with this type of injury mechanism, it would most likely affect the subcutaneous one, the bursa that's immediately deep to the skin right at the tip of the elbow. So it's very superficial, that bursa. And so when we have an injury mechanism like where we're falling on the flexed elbow or in hyperextension, we're likely to damage that bursa because it is so superficial. So when that one becomes inflamed, it'll blow up like a big golf ball right at the tip of the elbow. Thankfully, it doesn't cause, if the only problem is the bursa and not a fracture in the bone, if the only problem is the bursa, it doesn't restrict range of motion very much and it doesn't hurt that bad because it is so superficial. So it's not getting in the way of the joint. Versus if we have injury to that deeper bursa that's between the tendon of triceps and the bone, injury to that one does restrict range of motion and cause a lot of pain with movement. Okay, radial head fracture caused by longitudinal compression, like falling on an outstretched arm. Okay, so if we fall on an outstretched arm, that causes a longitudinal force, meaning a force that goes the long axis of the bones. So we fall on an outstretched arm, that puts a longitudinal force through the forearm and would cause compression between the radial head and the capitulum of the humerus. That compression, all those forces, would cause fracture of the radial head, which between the two bones, the radial head would be the weaker of the two compared to the capitulum of the humerus. That would cause a radial head fracture. Okay, elbow sprains. A blow to a flexed elbow may sprain the collateral ligaments. So collateral ligaments of any joint are on the medial and lateral side of that joint. So just remember, lateral collaterals. Okay, so the collateral ligaments are on the sides, both sides, the medial and the lateral side of any joint. So if we have a blow to a flexed elbow that comes from the medial side, that will cause an overstretching of the ligaments on the lateral side, so we would sprain the lateral collaterals. A blow to a flexed elbow from the lateral side would overstretch the ligaments on the medial side and cause a sprain of the medial collateral ligaments. And that's really true of any joint. Okay, so the force coming from the medial side would sprain the lateral collaterals, and then vice versa. Hyperextension of the elbow can sprain the anterior capsule or impinge the posterior structures. Okay, so hyperextension in the elbow would overstretch the structures in the anterior side, so that would be a sprain of the anterior capsule, but it also can cause kind of a crunch of the structures in the posterior side, which is why a hyperextension can also cause a fractured olecranon, like we talked about a couple slides ago. Okay, epicondylalgia. Anything ending in algia means pain of that thing. So pain of the epicondyles. Now I want to clarify that you may have heard the term epicondylitis. Usually we're referring to the exact same thing, but the difference is that if it ends in itis, we mean inflammation. Epicondylalgia is rarely actually inflammation. So epicondylalgia is the more updated term that's more correct in terms of what pathologically is actually taking place. So epicondylalgia acknowledges the pain in the region and doesn't specifically say if it's degenerative or inflammatory, because it actually is degenerative more often than it is inflammatory. So epicondylitis is not a very accurate term for pathologically what is actually taking place here. So lateral epicondylalgia is commonly referred to as tennis elbow because it happens more often in racket sports. It's caused by repeated forceful eccentric contractions of the wrist extensor muscles, which in tennis, that's what's happening in a backhand. So for a backhand stroke, there is eccentric flexion happening. Okay, so the wrist is in flexion and the wrist extensors are contracting eccentrically and then reversing as you hit the ball. So essentially it's the backhand stroke that would cause tennis elbow in someone who develops it playing a racket sport. Causes pain over the lateral epicondyle, decreased grip strength and pain with gripping, prevalent in racket sports, and especially is correlated with single hand backhand strokes. So of course, this is an interesting topic of research because it's such a prevalent problem. And what has been found is that there's a very big difference in the amount of lateral epicondylalgia that occurs when you compare people who have a two-handed backhand stroke versus a single-handed backhand stroke. There's significantly more epicondylalgia in someone who has a single-handed stroke compared to a two-handed stroke. And that's of course because in a two-handed stroke, you have your other hand who is that the forearm is able to contract concentrically to to contribute to the force instead of 100% of it being dependent on the eccentric force produced by the backhand, the single-handed backhand. Okay, lateral epicondylalgia. Excessive forces cause the tendons to break down faster than the correct type of collagen can be replaced. This is exactly what I described in the previous video where I talked about rotator cuff tendons. It's the exact same problem. So it's really tendinosis that is happening in this case, not tendinitis. So the type 1 collagen is breaking down faster than we can replace it with the correct type of collagen, but type 2 and type 3 and other weaker types of collagen can be produced faster and with less resources because they're weaker, smaller types of collagen. So we start replacing the strong, dense type 1 collagen with the weaker stuff. And so over time, the tendon is degenerating and becoming increasingly weaker. Okay, and so that's the foundation of all of the osis degenerative conditions. So like tendinosis, fasciosis, etc. Okay, so medial epicondylalgia, same exact thing, but happening on the medial epicondyle instead of the lateral and happening with different types of forces that are causing the problem. So medial epicondylalgia is commonly called golf elbow, caused by repeated, swift, powerful snapping of the wrist and pronation of the forearm. So like what happens in golf, which is why golfers are more prone to this. The mechanism is similar to lateral epicondylalgia, meaning that it's a degenerative condition of the tendons of the muscles that originate on that medial epicondyle. It's common in activities that include excessive flexion of the wrist and digits. So again, like golf. All right, a biceps tendon rupture. The tendon and aponeurosis of the distal biceps brachii degrades, causing a spontaneous rupture. So when this happens, it always seems spontaneous, but this generally happens after there has been tendinosis taking place over time. In general, that's usually true of most tendon ruptures. Most healthy tendons don't rupture unless there's a very extreme force that goes through that tendon that no healthy tendon could withstand. But most tendon ruptures that occur just during normal play or normal exercise or normal day-to-day activities, those tendon ruptures, they're not going through extreme forces, but usually what's happening is that there's already been tendinosis taking place where the wrong weak type of collagen is being laid down to replace the strong type 1 collagen. So over time, the tendon is getting weaker and weaker. And so then it only takes a normal amount of force to cause it to rupture instead of an excessive amount of force. So that's usually what's happening. And that's the biceps tendon rupture is no different. May also involve an avulsion of the radial tuberosity. So meaning the tendon may also tear off of the radial tuberosity rather than the tendon actually rupturing. So we talked about this a little bit in the video where I discussed viscoelasticity, because the rate of loading during the injury mechanism will determine whether the tendon ruptures or whether the tendon tears from the bone. So bone gets stronger when the rate of loading is faster. So the faster the injury mechanism occurs, the more likely it is that the tendon will rupture versus a slower movement in the same injury mechanism will make the tendon stronger and the bone weaker, and so then we're more likely to have an avulsion. So the same, and I mean, in either case, there was more force than the system could tolerate, so there was going to be an injury. But the rate of loading is what determined which structure became injured. So usually this happens during eccentric loading. And of course, we know that during eccentric loading, we're able to produce more force than during concentric, which is why this is more common in eccentric, because we're producing more force and that force is being translated through the tendon. And it's when the elbow is flexed to 90 degrees. So that's when we have the greatest amount of force being produced is during the eccentric, and we have the greatest advantage of the muscle at that angle. So most often when I've seen this happen, it's when somebody is lifting more weight really than they can lift, which in general is not really a bad thing. But if the biceps tendon is weakened, because over time they have a tendinosis condition that's developed, then when they're lifting more weight than they really can lift, and you get to that sticking point at 90 degrees, they're in an isometric or eccentric contraction because the weight is winning, so it's lowering and they're still fighting to lift it. And that's when this is most likely to happen. This also can happen, or an avulsion in general can happen in somebody who has abused steroids, as another example. In that case, it's not that any tendon has become degenerated or weakened, but the problem there is that the muscle has grown in size and strength disproportionately to the strength and density of the bone that it's attached to. So if someone abuses steroids, they're doing that to build more muscle mass and build more strength in their muscles. And we want to build muscle strength gradually to allow the strength of the bone that those muscles are attached to also grow in strength proportionately so it can withstand the forces that the muscle is applying to the bone. If the muscle is growing in strength faster than the bone is growing in strength, and it's doing that because of the steroids, as one example of how that could happen, then when that muscle exerts all of this strength that or all of this force that it's able to produce, and it exerts that on the disproportionately weak bone, then it can cause an avulsion. Okay, so that's another example. In addition to just having a weakened degenerating tendon, it could also just be because the muscle is disproportionately strong. Okay, neuropathy. Peripheral nerves can be injured by chronic entrapment. So like it's pinched between two structures. It could be impinged and pinched by a muscle. It could be trapped like in the carpal tunnel, for example. Could also be injured by repetitive tension or trauma. Okay, so we can have a direct impact to a nerve that could cause it to be injured, or repetitive tension. Like I once had a patient who had this chronic neuropathy. She had paresthesia and pain, tingling, all that in the forearm and in the hands. We could not figure out what was going on or what was causing this. And we eventually figured out that the problem was that she was, when she was driving, she had the habit of sitting like this with her elbow in this flexed position and leaning on the window. And so we discovered that the problem was that she was repeatedly stretching the nerve traveling through the posterior part of the elbow, and that repetitive tension was keeping that nerve in an injured state and causing the symptoms. As soon as she stopped doing that, the nerve was able to repair itself and the symptoms went away. So that's an example of repetitive tension causing a neuropathy. So neuropathy causes symptoms that radiate distally. So entrapment at the elbow may cause symptoms in the elbow, forearm, and or hand. So when we injure a peripheral nerve, what symptoms and signs we experience happen distal to the site of the injury. So like we could have an injury to the median nerve at the neck or at the shoulder, and the symptoms may only occur in the hand, or it could happen anywhere in the whole path all the way to the hand. So what that means is when there are any kinds of neurological symptoms, is that you want to check the whole pathway of that nerve for entrapments and injuries that could be causing those symptoms, and don't just assume that the entrapment is happening immediately at the site of the pain. So like an example of that is someone could be having traditional classic carpal tunnel symptoms, but entrapment of that nerve could happen at the neck, shoulder, elbow, or the carpal tunnel. So just because they're having classic carpal tunnel symptoms does not mean that they have carpal tunnel syndrome. And I've actually seen this in multiple cases where somebody went to a doctor and got diagnosed with carpal tunnel syndrome based on their classic symptoms. And I've even had people who have gone to the extreme of carpal tunnel surgery where it didn't actually correct the problem because the impingement was at a higher level all along. And so you want to correct the impingement where that is actually happening to help solve whatever the distal symptoms are that are occurring. Paresthesia is a sensation of pins, needles, or numbness. And so it's paresthesia, it's like abnormal sensation. And so the abnormal sensation would be the feeling of pins and needles, like that tingly sort of feeling, or it could be just lack of sensation. It could also include decreased muscle strength and abnormal movement, and can certainly involve pain. Okay, cubital tunnel syndrome is where we have the ulnar nerve trapped in the cubital tunnel. Cubital is the anatomical region of the elbow. Okay, so we're saying we have a tunnel in the elbow where the ulnar nerve passes through, like what we see in this picture here. So it's ulnar nerve entrapment or injury at the cubital tunnel in the elbow. So if we have entrapment there, we would have ulnar nerve symptoms. And it could include paresthesia in the 4th and 5th digits because that's where the ulnar nerve goes. And that would especially be worse when the elbow is flexed. Paresthesia is worse at night in this case. And it could also cause hand pain, grip weakness, and lack of coordination. Okay, radial neuropathy. The radial nerve may be injured at the elbow or, of course, at the neck or shoulder or wrist. But it could be injured at the elbow, causing sensory or motor dysfunction in the forearm and or hand. So the radial nerve is interesting because there are multiple branches, some that are only sensory and some that are only motor. So depending on where exactly the radial nerve is injured or impinged, you might have only sensory symptoms, only motor symptoms, or some combination of the two. All right, that is all I have, and thank you for watching.